Hello and welcome to the ENETS INCA Net Cancer Day educational webinar. We're so happy you're joining us here today for a little over 2 hours. This webinar is in honor of Net Cancer Day, which annually takes place every year on November 10th. Of course, this year, our program is on a Tuesday, falling after Net Cancer Day, after a flurry of activity online and in social media on the actual Net Cancer Day. We decided to hold this webinar to be a little more convenient on a weekday for all of you tuning in, as well as our speakers and panelists. So thank you so much. My name is Stephanie ALBAND, and I'm co-moderating today with Dr. Rocio GARCIA-CARBONERO, ENETS Chair from Madrid, Spain. We'll hear more from Rocio in a moment. Welcome, Rocio.
Thank you very much, Stephanie. I would like to join you with the welcome of all our people joining today's webinar. It's really a pleasure for me to co-chair with you this very important Awareness Day. And I'm sure we are going to be able to share a lot of very relevant experiences from patients, and I'm really looking forward to it. Thank you, Stephanie.
Thank you. I'm the INCA president and a patient advocate serving from Carlsbad, California in the United States. So please allow me an opportunity to introduce our amazing speakers, which are patient advocates and clinicians from around the world. They are as follows: Simona BARBI from NET Italy, Nehara BEGUM from a surgeon from Germany, Aleksandar FARSTAD from CarciNor, Norway, Hans HOFLAND, an endocrinologist from the Netherlands, Anna KOUMARIANOU, an oncologist from Greece, and Ilaria MARINONI, a molecular biologist from Switzerland. And then to introduce some of our panelists as well, we have Meredith Cummins from Neuroendocrine Cancer Australia, Wanda Helvet, a NET nurse from the Netherlands, Gregory Kaltsas, an endocrinologist from Greece, Wendy Martin, another NET nurse from UK, Mark MacDonald, past president of INCA, as well as from NET Patient Network Ireland, Marge Walker from CNETS Canada, as well as Lisa Yen from LACNATS here in the United States as well. Thank you everyone for joining. As people trickle in, we're looking forward to having an engaging discussion with you. If we could just go over our agenda briefly, that would be great. We have 4 sections we're going to address today. We're going to start off with most frequent symptom control. Part 2 will address treatment line sequencing and what are the rules. Part 3, we'll talk about new treatments and what treatments are on the horizon, what patients have to be hopeful for. And our last section will be dedicated to genomics. So before we jump in, we just want to take an opportunity and ask all of you in attendance a live poll question. Which continent are you from? INCA is, of course, stands for the International Neuroendocrine Cancer Alliance. And if you see the poll there on your screen, go ahead and answer. INCA represents 37 patient advocacy organizations dedicated to NETs around the world. So obviously we're international. We consider ourselves the global voice for NETs. So if you can take a moment and fill out the questionnaire so we can determine where everybody's from. And in just a moment, we'll see the results. I know Meredith is tuning in from Australia. She's always a pleasure to join from a terrible time relative to other parts of the world, such as where I'm from on the Pacific coast in the United States. So mostly European attendees today, with almost 80% as well as 20% from North America. So thank you so much for responding. It gives us a really good idea of who is in attendance today. So we will have an opportunity for questions and answers during this session. So if you do have questions, please submit them in the Q&A using the function at the bottom of the Zoom, as well as you'll be asked to fill out a participant survey that will appear automatically on your screen once you've left the Zoom webinar. And your feedback is really important because it will help us to improve future webinars. So with that, I think we should go ahead and get started. It's always really important to hear from our patients and have patients tell their own story in their own words. So to open up this part 1 of the session, we're going to talk about most frequent symptom control, and we're going to hear from Roy. This is a pre-recorded telling of his story. He is a men to a patient. So if we can go ahead and play the video of Roy telling his story.
Hei, jeg heter Roy FARSTAD og lever med medulær thyroidia-kanser, som en men 2A nettkreft. Dette en diagnose jeg fikk i 2000, og med meg så fant jeg ut gjennom en blodprøve. Det en familiær genetisk arvelig sykdom jeg lever med, noe som gjør at vi har en hel familie som lever med den diagnosen sammen. Min erfaring med å leve med nettkreft at dette her en diagnose som få kan noe om. Det en vanskelig diagnose å forstå. Også for oss som pasienter, men også for helsepersonell som ikke jobber direkte opp mot nettkreft. Derfor det jo litt sånn usikkerhet gjennom hva det som kommer rundt neste sving. Som familie så har vi jobbet tett opp mot helsevesenet. Vi har hatt en veldig god og tydelig samarbeid med vårt sykehus. Noe som har trygget familien veldig. Og gjør at vi sammen kan leve med en god diagnose, eller med diagnose sammen på en god måte. Det har jo alltid vært litt utfordringer. Det en del svulster som har blitt tatt ut. Jeg har operert 3 ganger. Og har selvfølgelig litt senskade på grunn av at jeg har tatt ut organ fra kroppen, og får en del smerteskade blant annet. Men når jeg har lagt opp et liv der jeg klar på at ja, der en del utfordringer, der må vi møte på best mulig måte, så det selvfølgelig bedre å klare å møte dem på en god måte. Mine tips til å leve med en diagnose at man må få en god kunnskap om egen diagnose. Jeg har jobbet mye sammen med mine leger til å forstå hvilken diagnose jeg faktisk har, og har selvfølgelig lest litt selv. Det som viktig at man snakker med helsepersonell for å få en forståelse av hva som kan komme, og hva som normalt. Jeg har alltid vært åpen om min diagnose, noe som jeg har tjent mye på. Jeg har alltid hatt lav terskel for å ta kontakt med helsevesenet, når ting jeg har vært usikker på, eller ting jeg føler ikke helt innenfor normal. Dette har gjort at jeg får tidlig hjelp, og får tidlig svar på de utfordringene jeg har, noe som at jeg slipper å leve i en usikkerhet. Det mange gode muligheter i å få god informasjon i Norge, og for å få kontakt med helsevesenet, både gjennom fastlege, sykehus og koordinatorer. Så det anbefales, og et av mine viktigste tips. Jeg har også vært svært aktivt i kreftmiljøet, gjennom pasientforeningene, noe som har gjort at jeg også har fått en del mestringsstrategier, fått en del kurs og møte mennesker som en lignende situasjon, noe som gjør at jeg får en bedre verktøykasse for hvordan jeg kan møte mine utfordringer. Og i dag jeg daglig leder i en pasientforening for tarmkreft, og har et svært aktivt liv, både gjennom jobb og gjennom privatliv. Dette hadde jeg aldri klart hvis ikke det var for jeg hadde vært så åpen og tatt hensyn når det måtte gjøres. Nettkreft en vanskelig diagnose for mange å forstå hva det og ikke ha forståelse for at alle skal forstå alt. Men snakke om det hjelper, og det å kanskje være ærlig og si den kreften jeg har nå, det en vanskelig krefttype å forklare, men det en jeg lever med og forklarer på best mulig måte. Det gjør at de som rundt deg får en større forståelse av hva det du opplever her og nå. Snakk med utfordringene du møter. Når du med fastlege, eller du med på sykehus på kontroll, ha en forståelse av hva du opplever selv. det er dine utfordringer som er viktig, og selv om du kanskje ikke tror det er en utfordring, så ta det opp med legen din, for plutselig så kan de hjelpe deg med det. Og det gjør også det viktigste. Den læringen jeg sitter med etter alle de år som pasient, er at det er viktig å ta utfordringer du møter tidlig. Ikke vent med smerte, ikke vent med tankene dine. La det komme tidlig frem at du har en utfordring, snakk med noen om det, slik at du får hjelp til å dele både tanker og får hjelp til å takle smertene på et tidlig punkt. Det gjør at du ikke må sitte alene med smerte eller tanker over en lengre periode. Og en delt smerte er jo halve smerte. Så viktig å få delt det meste med flest.
Thanks so much, Roy, for sharing your story. Roy will be a part of our panel discussion at the end of this section. And as you can see, his patient story, along with Simona's, will be presented in their native languages, which I think is really important as an international organization. So next we hear from Simona.
Ciao a tutti, sono Simona, una paziente NET e più precisamente sono una paziente di NET ileale con secondarismi epatici e addominali. Ma vediamo un attimo brevemente la mia storia di paziente che è iniziata nel 2010, quando a causa di un singhiozzo che non mi lasciava pace ho fatto una visita ecografica che ha mostrato una macchia sul mio fegato e lì è partita la mia avventura, diciamo così, il mio cammino. Dopo questo percorso sono stata inviata dal gastroenterologo che mi ha sottoposto a diversi esami, tra i quali la biopsia, che ha dato esito negativo, per cui sono stata inserita in un follow-up semestrale, quindi non ci ho pensato più per un po' di tempo. A dire il vero, non ci ho pensato, non è vero, perché mi sentivo strana, sentivo che non ero tranquilla di quello che mi avevano detto. In ogni caso, i controlli sono passati uno dopo l'altro e dopo 2 anni qualcosa sembrava essersi mosso, per cui ho chiesto, visto la mia incertezza, la mia insicurezza, ho chiesto che venisse fatta un'altra biopsia per tranquillità. E infatti dopo 10 giorni dall'esame sono stata chiamata e mi hanno comunicato per la prima volta che probabilmente soffrivo di un tumore neuroendocrino. Era la prima volta che lo sentivo e quindi immediatamente mi sono attivata, come fanno tutti del resto, sul web per vedere di trovare qualche informazione in più. E l'ho trovata anche se non mi dava completa soddisfazione. Mi hanno mandato dall'oncologo. Finalmente ho incontrato il mio oncologo a Modena, quello che mi avrebbe poi seguito in tutti questi anni. Parliamo del 2012, quindi la mia diagnosi è arrivata dopo 2 anni di dubbi e di incertezze. Lui mi ha spiegato con calma, con parole semplici, in modo che io comprendessi di cosa si trattava. Mi ha tranquillizzato sul fatto che la patologia è una patologia a lento sviluppo, per cui potevo stare abbastanza tranquilla sul prossimo futuro e che comunque mi avrebbero accompagnato negli ulteriori esami da fare per vedere dove era il mio primitivo, perché quello che vedevano nel mio fegato erano i secondarismi, quindi erano metastasi dati da un primitivo che dovevamo scoprire dove fosse. Quindi prima di uscire mi diede un depliant e mi disse che c'erano altri pazienti come me, cosa che io del quale chiaramente non ero informata. Mi disse che c'era un'associazione che si occupava dei pazienti con tumore neuroendocrino e questo al momento non diede importanza a questa cosa, ma poi capii che mi aveva lanciato davvero un'ancora, qualcoa a cui aggrapparmi. Quindi gli esami sotto Natale dimostrarono che la PET captava nella zona ileale, per cui in gennaio venni sottoposta all'intervento chirurgico, alla resezione dell'ultima ansa ileale e a un'emicolectomia. Poi termoablarono le mie metastasi epatiche. Quindi il mio percorso acuto di paziente era stato affrontato in questo modo. Poi mi disse una cosa che un farmaco che io ho chiesto cosa avrei dovuto fare poi nei mesi successivi, a parte i follow-up, e mi disse che dovevo iniziare a fare una terapia senza data di scadenza, perché non si sapeva per quanti anni o se l'avessi fatta per sempre, con un analogo della somatostatina, una puntura ogni 28 giorni. Questo mi spaventò perché mi dissi, ma santo cielo, ma com'è possibile? Andrai a leggere anche in questo caso, i miei capelli, accidenti, come farò? Come farò? E non sapevo che mi stavo avvicinando ad un compagno che è stato mio fedele compagno di viaggio per questi 12 anni e che negli anni ho imparato davvero col quale ho imparato a convivere. In primi tempi qualche disturbo, mi dava qualche disturbo, tipo nausea, un po' di diarrea, però poi col tempo sono questi disturbi, questi effetti collaterali sono quasi spariti e conviviamo pacificamente, anzi il mio corpo mi dice quando è necessario fare la puntura. Io mi alzo, mi sento un po' strana, guardo il calendario ed è ora di fare l'iniezione. Quindi anche questa cosa è stata superata ed è stata vissuta in modo con la quotidianità, perché ci si abitua a tutto. E questa è una cosa che ho imparato in questi anni, perché per riuscire a vivere una vita normale bisogna passare dall'accettazione, bisogna accettare la malattia e poi ripartire, perché non si può fare altrimenti. Per cui questo è stato quello che ho cercato di fare. E questo è anche quello che ho messo in pratica, ho cercato di mettere in pratica anche con l'associazione pazienti della quale in quegli anni poi presi parte, anche attivamente proprio, perché ho capito che condividere la mia esperienza, condividere il peso che portavo con gli altri che parlavano la mia stessa lingua era un modo anche per aiutare me stessa oltre che gli altri. Sono passati 9 anni nei quali ho fatto la mia vita normale al lavoro, come moglie, come mamma, come figlia, quindi proprio una vita che io posso definire normale, perché era una nuova normalità, ma comunque non ho dovuto rinunciare a grandi cose nonostante la malattia. E poi è arrivata la recidiva che abbiamo affrontato perché col mio medico, col mio oncologo, abbiamo sempre parlato in modo molto aperto perché io per lui ero una risorsa di informazioni perché il paziente lo può essere e lui con me è sempre stato molto chiaro e mi ha aiutato ad affrontare le prove che la malattia mi ha messo davanti senza avere troppa paura, con fiducia, ecco, con fiducia che insieme potevamo arrivare ad ottenere dei buoni risultati. E così è stato, quindi abbiamo fatto alcune operazioni, abbiamo altre chirurgiche, eccetera, e ora sono qui, dopo quasi 12 anni, a raccontare la mia storia, a condividerla con le altre persone, a cercare di mettere a frutto quello che ho vissuto in questi anni, aiutando gli altri, anche perché non ho mai considerato questa una battaglia. Non mi piace la parola battaglia, non mi piace la parola guerra, perché in questo percorso non ci sono vincitori, non ci sono vinti, ma ci sono soltanto persone che cercano di andare avanti e di cercare di vivere la propria vita nella normalità. Il paziente e il medico insieme sono veramente un tandem che se camminano e pedalano con lo stesso ritmo possono davvero andare avanti e senza farsi troppe aspettative, ma comunque andare avanti insieme. Grazie.
So well done, Simona and Roy. I look forward to hearing additional insights from you during our panel discussion. Thank you so much.
Ciao a tutti.
Before I introduce our first speaker, I would like to remind you that during the entire presentation, you can submit your questions in the Q&A tool down in the bottom of the Zoom bar. So feel free to do that, submit your questions at the bottom. And now I'd like to introduce our first speaker. This will provide our clinician's perspective, and I'd like to introduce Nehara from Germany to present.
Thank you so much, Stephanie. Can you hear me?
Yes.
Okay, that's great. Yeah, dear colleagues, dear patients, I'm really honored to be part of this session, and thank you very much to Roy and Simona for sharing their history with us. The next slide, please. Neuroendocrine neoplasia are very rare. We all know this. Next. And in the German NET registry, we find the small intestinal and pancreatic NEN to be the most frequent primary entities. And on third place, the neuroendocrine CAP syndrome, which means that the primary is not known. Next, please. The most frequent metastatic sites are the liver and the local regional lymph nodes, and around 50% of NEN are found to have distant metastasis at initial diagnosis. Next. And this is one of my very favorite slides from Professor Arnold. This shows us on a spot the heterogeneity of NEN and the and the complex pattern which is behind this, and that lead us to the problems we have to face when we deal with neuroendocrine neoplasia. They are very rare. They are very heterogeneous and complex. So there is also the colleagues don't dare often to deal with this. We have multiple primary sites, which defines different therapeutic options. We have most often unspecific symptoms, and in rare cases, specific hormonal symptoms, which needs to be recognized then. Next, please. The clinical presentation of NEN, most of the neuroendocrine neoplasia do have asymptomatic clinical presentation with diffuse abdominal pain, nausea, diarrhea, but all symptoms which can rely on many other pathologies. The carcinoid syndrome, which is defined by flush and diarrhea, is quite rare, 15 to 20%, depending on which registrar you look at. Hypoglycemia, hypercalcemia, these are rare symptomatic hormone symptoms behind which the rare insulinoma or gastrinoma are diagnosed. Next, please. So the carcinoid syndrome, just in a short, means the hypersecretion of serotonin, mostly found by NEN of the small intestinal, but rarely also of other primary sites. And this is due to a hypersecretion of serotonin. When we find liver metastasis, then it can act on many sites of the body. And next, please. Next. And the problem is that we have changes in all over the body. The carcinoid syndrome is most likely, but we also have to think of the carcinoid heart disease, which means changes of the right valves of the heart, which can lead to cardiac insufficiency. Next, please. So, which problems do we face in our NEN outpatient clinic? And we are a surgical clinic, so we see many patients after surgery in the follow-up. We see very often, and this is the leading symptom, I would say, diarrhea. And diarrhea is often faced by the patients as normal, because nobody told them that to have diarrhea like after bowel surgery is not a normal constitution. But many people do have it over many years, and they don't talk even about it. You have to ask them actively. And the next, diarrhea leads to malnutrition, to weight loss, to impaired quality of life. People don't leave the house and are bound to the house, and also vitamin deficiency. And another question which is often comes, is the disease inherited? So it means we have to look for inherited disease, and these are all the features we do face in our outpatient clinic. Next, please. The reason for diarrhea are multiple, and this is the problem also in diagnosing NEN. Here you see a flow chart for reasons of chronic diarrhea, and in the middle you see there are also neuroendocrine tumor listed as one specific reason. Next, please. And the reason for diarrhea we see in our outpatient clinic is most likely or most often small intestinal surgery, bowel surgery. And the reason behind is the loss of biliary acids, especially if patients have the resection of the last ileal loop like Simona did. And so this is a collagen diarrhea, but we often also see bacterial overgrowth, which is very simple to treat, but you have to think about it. And of course, if the tumor is still inside, it might lead to ileus due to stenosis of the bowel. Next, please. The treatment of diarrhea behind the specific tumor treatment, which will be discussed by Anna in the next speech, is also very simple if you think of it. It's cholestyramine, which binds the biliary acids, which are not resorbed anymore in the small bowel. And this is a very simple medication which can really help and improve quality of life of patients in reducing diarrhea. Next, please. We also have many other treatment options, especially in the early post-operative episode. We sometimes need to use codeine drops or other medications which can be normally reduced in the after 6 to 12 months after an operation or surgical procedure. Next, please. This is also one important case. In gastrinomas, we need to think of proton pump inhibitor. Using this can reduce immediately diarrhea and other symptoms of the patients. Next, please. And last but not least, we have another medication, telotristat, which can be used for diarrhea if the biotherapy or other specific tumor therapy is not enough to control the carcinoid syndrome. Next, please. So the challenges we face in NEN, and I will show you one example for it, is one, the correct and timely diagnosis. And we've seen that there are many reasons for delaying the diagnosis. Then next is the correct treatment. And of course, after the first treatment, the adequate company of the patient along the disease course. And this means to see the patient regularly, to ask for side effects, and to help improving the quality of life. Next, please. And here's only one patient, one example from the outpatient clinic yesterday. A young woman, typical history, flushing and diarrhea over 2 years. After 2 years, she got her practitioner to send her to a colonoscopy. Ileal NET was found, and Then the resection, the operation was proposed, but instead of an oncological hemicolectomy, which would be the adequate therapy, this patient became a small bowel resection in kind of ileocecal resection. It's not enough because the lymph nodes are not removed. The patient, after this, the patient Googled and found us and came to see us to complete the diagnostic workup. This means the DOTA-TOC PET wasn't done before, so we will complete this now and lead the patient later to a complete complementary or second operation to do the hemicolectomy. The next, please. And so I can summarize what we need is, of course, specialized centers. And I think the first ENETS center was audited in 2009. It means 15 years ago. And worldwide, we have 70 centers at the moment. So we have done a lot and we have achieved a lot, but the awareness in this field also among the general practitioners must go on. And we need cooperation with the patient and patient organization because we can learn of the patient histories and there is still a lot to do. Next, please. And learn from the patient, go and meet the patient. And I really like the what Simona says, the tandem, that the doctor and the patient are together on a cycle and have to have the same pace. So I think this is a nice nice picture we should keep in our mind. And next, please. I think this is, yeah, I would like to thank you for your attention, but I also want to thank, I'm very grateful to the founders of ENETS and especially Professor Plöckinger, Professor Wiedenmann, who were mentors to me. Thank you very much.
Thank you. Thank you so much, Nehara, and thank you, Simona and Roy, for sharing your very important patient stories that sometimes can teach us so much. So we have now 15 minutes or a little bit less to discuss, and in the panel discussions we have also besides our speakers Roy, Simona and Nehara, we have also Wanda Jelvoet from the Netherlands joining us, and Professor Gregory Kalsas from Greece. So we can now all join together to talk about the topic, this first topic, which is symptom control, and I think more than symptom control. I'm gonna check on the incoming questions, okay? Okay, so from Tony McCourt, we have here a question. Any update on the use of histotripsy in Europe, apart from the trial ongoing in Leeds, UK, for treatment of liver nets? High-intensity ultrasound seems to be a very promising possibility. Maybe that would be for Nehara or Gregory to maybe answer this question. Gregory, you want to start?
Hello, everyone. Thank you very much for inviting me to participate in this panel. To be honest, I'm not aware about this study that is running on in the UK, but I mean, means in trying to decrease the hepatic tumor load, if this is feasible by several techniques, is something that we use and is mandatory, particularly in cases that we cannot control the secretory syndrome. So this particular trial, I'm not aware of. I don't know if the other participants in the panel are aware of this particular trial.
And neither me, I'm not aware about this, but I think this would be something, or to use the high density ultrasound in the first step when we have to detect or to get to the right diagnosis. If I'm I understand it right, but I have no
Yeah,
information.
I guess it's about different techniques of treating liver mets, which we of course use, and we use also a little bit different depending on the local expertise we have, because some centers are really experts in a particular technique versus others. But of course, this is a very useful approach to control particularly symptomatic and functioning tumors. So I would like to ask our patient storytellers. So starting with Roy, you've talked in your story a lot about all the challenges you face, but you haven't named specifically what are they. And I would like to know what's the main challenge you face? Is it about symptoms you suffer that you cannot share, or it's not in an appropriate time, or your lifetime risk being, having a hereditary syndrome?
Yeah, thanks. I think the main problem is that I have a lot of pain coming after I taking out my thyroidea, and I don't have calcium in my body, so I'm struggling a lot, like with the working out. Then I get a lot of pain after working out. I get a lot of infections after physical working. So I think that's the main problem. And when we see in the symptom, it's because I will get in the adrenalina. I will get this metastatic in the adrenalina, and it's problematic to find the symptom for when's the adrenaline is coming or not. So we are going a lot to checking it up all the time. And the doctors also a little bit, they need always go to a specialist to get the right answer. So we are using a lot of the specialist to getting the right answer. So it's a little bit difficult to find out what's the right symptom and what's the not. So when I was finding it out, I had no symptoms at all, and I had 18 tumors. So there was we didn't have one symptom at all. So, and I was the same with my nephews that's having tumors, but no symptom at all. So we are struggling a little bit. What's the symptom to look for? Yeah. Mm-hmm.
So I guess it must be really, really stressing when you share your problems with physicians, and physicians don't know much about your disease, right? I guess that's another big challenge you may face in your patient journey. I don't know. Sorry, you want to say something?
Yeah, but I think that's the good thing is that when we're having this good communication with the doctors and they're telling us that they are a little bit unsure, but they are doing the best, we're having a good discussion with them, then then we see, okay, this is something new, they have to check it out, and they have control, and that's a good thing. I mean, they're always getting the new searching and everything. So yeah, it's not so stressful when we're having the good discussion.
I think Wanda wanted to make some comment.
Yes, thank you for inviting me to be here on this panel. And Roy, thank you for sharing your story with us. I have a question. It's maybe not that being in the symptom control thing, but I was wondering because of, I think it's an unmet need in the world to take care of younger patients dealing with cancer and all the problems that's coming along, and even with having a syndrome, a different kind of diagnosis in one. I was wondering, did you miss something like age-specific care? In our country, have the AYA care for adults and young adolescents. It's like a special care, taking care of the whole, seeing the patient at the whole. So every question about disease, but also questions about life issues, because if you're a younger patient, then you're dealing with different kind of life questions during your patient journey. And I was wondering, is there any attention for that in your country, or can you comment on that?
Yeah, we have when you're a child, you have this child care you have a special doctor for children and with the parents together. But like me, I'm a young patient. We have this cancer coordinator in our hometowns that we can contact. They will help you with everything you need if you like. Yeah, so they can talk with you if you have problems. They can talk with your doctors. Yeah, so I think.
But also like insurance questions or
you know, in Norway we don't need so much insurance
okay.
because the healthcare
Good
system
thing.
is free.
Good.
You get the best healthcare system in the public and it's free.
Yeah.
So we don't. It's not so normal to have that. If you have some, some of them having insurance, but you don't need it. And you also get pay from the government when you're sick leave and everything. So you're pretty insured in Norway. Yeah. So.
Okay.
Yeah, and also if you're having parents can, and also parents, if you have children that sick, the parents get sick leave and full salary. So yeah.
Good. Stephanie, you have your hands up.
I just wanted to ask a question of the clinicians on the panelists. Obviously, Roy and Simona are very good at communicating their symptoms. And I know it's probably still a challenge, but obviously you're very proficient at and have a good relationship with your providers. But if our clinicians could talk a little bit about some tips and tricks, including our net nurse, I think would be very useful, and how patients can communicate with their team effectively about symptoms to make sure that they're heard and understood.
Do you want me to take the question? Yeah, okay. That's a very important questions because you know, when the patients come, we just ask them sometimes, you know, you have flushing or diarrhea, and we expect them to give us a yes or no answer. But sometimes, you know, they're not very familiar with these terms. So we have to be very explicit and try and let them understand what exactly are the nature of the symptoms that we're seeking for. So you have to take some time to try and be sure that the patient really appreciates what they're talking about. And you have to try and find simply words and terms to try and explain, you know, the nature of these symptoms. This can be a little bit more tricky in cases that you have syndromes like the Rocio has, because symptoms can be really vague and they can fluctuate as well. So you have to take time and try and inform the patient what kind of symptoms that they anticipate, because in this particular syndrome, you can have different tumors in different time of evolution in different organs. So it's become a little bit more complex. But yes, indeed, you have to make sure that the patient really understands what you're talking about. And I do spend a lot of time, and, you know, sometimes I can be very explicit and make draws on the patient so you can understand what they are going to experience.
Okay, I may get the very last question from the audience, but please a very quick answer because we need to move to the next topic. We have 3 more topics to go. So does somatulin and PRT also contribute to symptoms such as diarrhea?
For sure, yes. These are, of course, treatment options we always include in our in the setting of fighting against diarrhea. But sometimes it's not the tumor itself, but other causes which I showed, which lead to diarrhea. But if it is the tumor or tumor progress, then TACE or biotherapy or tumors symptom leads to symptom control.
Okay, so thank you very much. I guess, Stephanie, we are going to move to the next topic now.
Thank you, Rocio. So moving on to our second topic, we will be discussing treatment
Thank you.
lines.
Sorry, I forgot to thank all the speakers of this section.
Yes, thank you so much. I think some of them have to leave.
Simona and Roy particularly, you are very generous to share your stories. I think you helped a lot with your own experiences being made public. Thank you so much.
Thank you.
And
Thank you.
Gregory
Thank you.
and Nehara.
Yeah, pleasure.
And Wanda.
We're going to move on to our next section of treatment line sequencing, which I think is an evolving topic with evolving information. And we have our expert clinician presenter, Dr. Anna KOUMARIANOU from Greece, who will be presenting on this topic.
Thank you very much, dear Rocio, dear Stephanie, dear colleagues, dear friends, dear patients. I'm very honored to be among you and discuss today about the treatment like sequencing in neuroendocrine tumors. What are the rules? Next slide, please. We heard a lot of nice information from Nehara earlier, discussing about neuroendocrine tumors, and that most of the organs in the system can be affected. What is very important for us clinicians when we meet for the first time a patient is to hear their story, to hear the symptoms, to hear any kind of information in relation to their tests they have done until that moment. But one of the most important tests that is of great value to us in order to decide the treatment is the rate of proliferation of their cancer cell, which is a number that we identify in histology and is called Ki-67. So Ki-67 is a crucial information we need in order to decide what will be the treatment and discuss everything within the multidisciplinary meeting and of course with the patient itself. Next slide, please. Of course, the cancer cell of neuroendocrine tumors has other important aspects of great interest to us. And one of the first, one very important aspect is whether it expresses somatostatin receptors. And this is very important because we can target somatostatin receptors with drugs. This the information we can get from specific tests, like for example, a gallium PET scan, or from histological tissue analysis. The second very important information we need to get from the cancer cell in relation to this cancer cell is whether this produces any hormones, as we heard earlier as well. So these are the three more important information we need to start discussing about treatment. Next slide, please. And of course, you know very well that this is a rare type of tumor and it needs expertise to treat them. So in order to achieve that and to have a homogeneous treatment across different centers in the world, we need to have some guidelines. And the guidelines, like the one I'm showing here on the right, are coming after long discussions among the clinicians and the experts in the field. These guidelines help us have a homogeneous treatment, as we said earlier, but also to keep some common language between us in order to communicate the problems of the clinical problems and of course the results of the treatments we have. So there are all these sets with information from the patient on the table, and we do multidisciplinary meetings and we discuss all these data together with the evidence that exists in the literature and what the experts have decided within these guidelines that I have indicated to you here. Here you can see, for example, that these are the guidelines that are related to the small intestinal NETs or the NETs or grade 3 NETs. And you can see below these three groups that these are further divided based on the Ki-67, the rate of proliferation, and whether they express or not somatostatin receptors. Based on all these complicated but crucial information, we then go on to decide the treatment strategy. Next slide, please. And treatment strategy is very important because it has to be personalized for each patient. So one of the first questions that will come along during the multidisciplinary meeting is whether the tumor is operable. And of course, if the tumor is resectable, we need to go ahead and resect the tumor. On the right here, you can see a patient who had resectable tumor with a couple of metastatic sites that were all excised. And on the right side, you can see the same technique, the gallium PET scan, which is negative, indicating a very good oncological resection. But if the tumor is not resected, this is not possible, at least at the time we speak and we see the patient, we need to start to consider whether we are going to start or not some treatment. And the first line treatment that is most commonly used, of course there are exceptions, but let's call, for the sake of this discussion, the most commonly used first line treatment are the somatostatin analogs that help slow tumor growth by targeting the somatostatin receptors on tumor cells that we discussed also earlier. Next slide, please. Once the first line treatment fails, when the tumor comes back or starts to grow again, then we need to think about second line treatment. And the second line treatment for the majority of the patients may be a targeted therapy. And we have two different types of targeted therapies. One is the radioligands, like peptide receptor radionuclide therapy, that delivers radiation directly to tumor cells by targeting the somatostatin receptor, or with drugs that are taken orally, tablets, that are called targeted therapies like everolimus or sunitinib, that act by blocking specific signals that promote tumor growth within the tumor cell. Next slide, please. And again, many years later, the patient can still experience progression, and then we need to consider some other form of treatments. And of course, there are several types of treatments, but I'm just indicating here one commonly used, which is chemotherapy by using oral drugs, CAPTEM, capecitabine and temozolomide, which is very well known for its activity and very good toxicity profile. Other treatments are underway, and we will hear more in the next session. And of course, there are several centers that have clinical trials to offer to the patient as a further line of treatment. Next slide, please. So what influences treatment decisions and treatment outcomes is multifactorial. Some parameters are patient factors, for example, the age, the overall health, comorbidities, genetic profile, but also tumor factors in relation to the Ki-67 we discussed earlier, the differentiation grade, how heavy is the tumor burden in the body, what is the rate of progression, the symptoms, etc. And of course, these considerations, together with patient preferences, help guide the selection of the most effective and personalized treatment approach. Given the typically long survival associated with this disease, treatment decisions consistently prioritize maintaining quality of life. Next slide, please. We heard two very nice stories from Roy and Simona. And we heard how tortuous and long their path is. This reminds me of Ithaca. Ithaca from Odyssey of Homer is where we want to arrive. And of course, where we want all to arrive in this case is cure of NET disease. And of course, this is a long and tortuous way. And as the Greek poet Constantine Cavafis said, you are on your way to Ithaca, we are all on our way to Ithaca, may the road be long, full of adventures, but also full of knowledge. Let's enjoy it. Thank you very much.
Thank you, Anna, for this nice summary and this nice poem to finish it. So we are very pleased to have joining this panel discussion. Also our colleague from the US, Lisa Yen, and March Walker from Canada. Welcome. And Wanda is staying also, Stephanie, and Nehara and Anna. So I guess I will start with a question that came in from the audience, Anna, from Dawn Marie. She is asking, does Ki-67 increase over time as the disease progresses?
Thank you very much for this very nice question. For some patients, of course, Ki-67 may increase. And this is the reason why we may repeat biopsies in these patients when the disease progresses from one treatment line to another. So I hope I have, this also influenced the treatment choice based on the results. So I hope I have answered your question.
Thank you, Anna. So anyone from the panel want to raise any question or comment?
If I might, thank you for that excellent presentation. I thought that was very wonderful overview and inspiring as well. You know, you talked about different lines of treatments, and I know from the patient or patient caregiver perspective, it can feel very confusing and overwhelming. How do you decide when to switch treatments? I know you kind of talked a little bit about it, but is it based on symptoms or scans? And sometimes the patients will see a little growth on the scan. Does that mean that if there's some growth, the tumor's bigger, it means you need to stop what you're currently taking and switch to something else?
You know,
That's a very good question, Lisa. Thank you, Anna. Go ahead.
Okay. Thank you very much for your question, Lisa. You know, for us clinicians, we are not in a hurry. So many times we don't run to change the treatment, particularly if we see very, very small progressions. So for very, very small progressions that do not cause any symptoms to the patient, and we don't see any major differences on the scans, you know, there are some criteria we use. I don't want to go into many technical and medical jargon, but many stick on the same treatment if the patient is well, and we are not in a hurry. So if the disease doesn't cause great problems, we don't change the treatment. So I agree with you.
Yes, I guess there are many different patient pathways and treatment sequences that are really, really varied. And I guess as clinicians, we act according to how the disease behaves. And I guess we all tend to be very conservative to switch therapies in slow growing, asymptomatic tumors, you know, patients, you know, like Simona's testimony in the first topic, you know, that has been for 14 years, you know, going on. She's doing pretty well. So we don't have so many treatment options either. So we shouldn't just waste them very quickly either unless we are facing, of course, a more aggressive and rapidly evolving disease. I think March Walker wants to make some comment.
Hi, thank you. Yes, as a patient, I found one of the biggest challenges was for the first 4 years, I was seen by an oncologist that was not a NET specialist. And often it felt like there was no standardization in the nomenclature. You know, the words tumor and lesion and things like that were interchanged, and it felt absolutely overwhelming. So it leaves a patient doing their own research and seeking support groups. And I know CNETS has been absolutely a lifeline for me. But as of yesterday, I was able to actually see a NET specialist, and it opened up, it was a whole new ball game for me. And so I'm wondering whether there is any move towards global recommendations for a standard guideline that oncologists that aren't necessarily NET specialists would be able to be educated in. Is that a far reach?
Well, I think Rocio can really weigh in much more eloquently on the ENETS Centers of Excellence. So but I do understand that feeling as a patient or a caregiver when you finally get to the right team. It's like a breath of fresh air. Oh, I don't have to know about all this. I don't have to navigate my own care. So, Rocio, if you wouldn't mind just talking a little bit about the Centers of Excellence. I think they're a really great resource. I know there's one in the United States. There's plenty in Europe, but please go ahead.
Yeah, well, there are two things. One is getting excellence of care, and the second thing is to have common guidelines that, you know, less specialized centers can access, and you know, for people that see just a patient with a NET once in a while and is not very familiar with it, can really, you know, have a sort of a quick guide to how to proceed. Because we talk a lot about, you know, centers of excellence and excellence of care, but there's a problem before getting to that, which is getting the correct diagnosis. And before you even know it's a NET, what's bothering you. So there are many steps where we need to, so it's not all about centers of excellence. It's also about broadening the knowledge to get to from primary care physicians to less specialized specialists, and then towards the centers of super specialized. Of course, ENETS has launched since many years now this program of centers of excellence, trying to really accreditate centers based on a very, I mean, it's really tough exam they do to centers in many ways, in terms of all disciplines, in terms of numbers too, because you can study a lot, be very smart, but if you don't see enough patients, you will not get it either, you know, properly. You will not get a full picture of it either. So and then you know, they you know, really multidisciplinarity, the true multidisciplinary and the coordination of the full team in a hospital is also very, very important. So this was launched in the beginning as a global, I mean, anybody could apply, and then we have centers of excellence in the US and also in Australia. But it got to be so big because there were people wanting to apply from China, from other countries, and there was some budget limitations. So unfortunately, you know, a couple of years ago, the decision was made to focus on Europe, but that's because our resources are limited, not because we are not interested, but because we do audits, on-site audits, and that's very costly and so on. But I think we are very prone to share our experience and with other continents and other countries, because I think it's a very, very good model to move forward. And then there's the issue with the guidelines. So we have in Europe the ENETS guidelines, we have the ESMO guidelines, then we have, every country has its own guidelines. Even within a country, we have the guidelines from the oncologists, the guidelines from the endocrinologists, and so on and so forth, you know. And then we have the US NCCN, the NANETS, and then we have ASCO guidelines. And so which guidelines do? And sometimes, you know, you see the same authors of all these guidelines, a lot of shared authors. And sometimes I feel it's a bit of a waste of efforts and resources to do all these parallel guidelines that in the end, by the way, you know, because of the I had to give today precisely an overview of all guidelines. So in the end, I think they pretty much all tell very similar things in a different way, right? So I think it can even get a bit confusing. But it is true also that drug approval, there are differences. Drug approval and drug reimbursement, there are regional differences, and also expertise, there are regional differences that also need to be assessed, addressed. And so I also understand these regional issues that need to be addressed, but guidelines are very useful for the community oncologists, I think, and community physicians in general, that you know, are not super familiar with this. Too long of an answer. Please, more questions. Wanda, Nehara also. Wanda first, maybe?
Yes, thank you. I would like to comment on that from a patient perspective, maybe, that I always tell my patient that we have an MDT. So the decision that's been made with your doctor is not only with this doctor, it's also the team behind it. So that's also, I think, important to share with your patients that that if you are having an MDT, and I think that's really necessary in this taking care of these patients, that the decisions about different treatments or switching to another treatment, if it's necessary, that's been made with a team of doctors, not only by one sometimes. And also that the different protocols that are there, sometimes you differ from that as a patient. So it's really necessary to be personalized for that patient. You cannot, sometimes you can fit a group of patients in one protocol, but we've seen a lot of things, different things within this group of patients that goes differently, and then you need to change another pathway. And I think you need to be I think you need to be aware of that it's not going to fit in just one pathway. Sometimes you need to go right, or sometimes you need to go left, and that's why you need the MDT for that.
Yeah. And I think the Center of Excellence, it's about that too, because they really examine the full team, right? The pathology, what was the quality of your surgery, what's the quality of your nuclear medicine specialist, and so on. So I think that is really, it's not only about the head or the one person that may be very super physician, but you really need a full team to work on that. Nehara,
Yes,
you
sure.
have your hands up.
Yes, sorry, just
a long time, I'm sorry.
No problem. I just wanted to say that I think Lisa raised a very important question, and I totally agree to Anna and to Rocio and to Wanda. And I think this is most important, not to waste our therapeutic options and not to react on every small changes. And of course, the MDT is very important. And but sometimes it's really difficult to explain to the referring oncologist or practitioners that we don't change to the next therapeutical options because of a small change in the CT scan or something like this. And we try very much to go to the next options after looking at the symptoms of the patient. So this is also necessary, not to look on the scans only, but also to see if the patient is impaired by this, or this is the leading point for us to look at the patient's symptoms as well.
Yeah. If I might add also, you know, I've been supporting my husband with metastatic advanced pancreatic NET for about 10 years, but I think most of us, all of us, have friends and family who have some other kind of cancer. And so when you get a diagnosis of cancer, or your loved one does, your friends, family, yourself, it's easy to extrapolate the conceptions you have of cancer, of the goals of treatment being to get rid of all the tumors. And so I know, Dr. Anna, you talked about the goal being quality of life. And can you talk a little bit about how the goals of treatment might be different with neuroendocrine cancer? And we might not want to take out every single tumor versus how you think of it with other cancers?
Thank you very much, Lisa, for your excellent question. Indeed, when I first started to work on neuroendocrine tumors with Gregory Kaltsas, who is my mentor, I tended to be very prompt into changing the treatments once I was aware of some small change in the CT scans. So you are absolutely right. This is a different mentality, and this is why we need expertise in the field. Everything about neuroendocrine tumors is different compared to other oncological practice. So we need to stay tuned. We need to be always in the context of the multidisciplinary meeting. We need to be ahead and be aware of all the new things that come in the field. And of course, follow all the guidelines, because we always do different things for each patient, but we need to be within the context of what is necessary for neuroendocrine tumors. So I totally agree with your observation, and it is tricky to understand net medicine, and this is why we are very much now looking forward to enter into the era for the net how do we call it, specialization that we have started through ENETS. So maybe Rocio would like to talk about this, because I think it's crucial.
Yes, let me go. I'm sorry. There are 5 questions that came in from the audience. I would like to address the most of them. So please try to get short answers. Okay. First question: what about G3-NET and NEX? Okay, yeah, that's very right, because we're always talking about low grades. What do you have to say about that, Anna?
Of course, these are more rare. Thank you. Tumors. Thank God. So I don't have time to explain all the treatments. Of course, the path for NEC G3 is different. Most of the time there, we need to follow other lines of treatment. Sometimes we start with chemotherapy based on all the parameters that we gather from each patient.
And then next question is from, how do you qualify for a clinical trial if the clinical trial is not taking place in your country?
Well, this is difficult, but this is one of the great efforts that ENETS is currently trying to address, which is to generate and approve centers of excellence in all the countries. And through centers of excellence, you can participate in a trial most of the time.
And I guess the last question, sorry, should NET be managed by endocrinologist or oncologist?
It is very important that all the specialists participate in treatment decision for your health. So it's not or, it's and. So an endocrinologist and an oncologist and then surgeon and a pathologist and a molecular biologist. We need all the expertise.
So thank you. Thank you very much, Anna. Thank you very much, all the panelists, for your excellent contributions. And then now we are going to move forward for the third topic of the session. Stephanie?
Thank you so much. In addition to the comment that Anna just had about expertise in all of the specialists, I think we also need to include our primary care providers in that discussion as well, because they can support, diagnosis and monitoring of our patients as well. And INCA has a great resource that they've actually just launched on Net Cancer Day to educate primary care providers on NETs. So encourage everyone to help us get that resource out there. It's a continuing medical education activity that's available on the INCA website. But with that, I would like to introduce our next speaker. We're going to now shift gears a little bit and talk about new treatments and what's on the horizon, what patients have to be hopeful for. So with that, I would like to introduce Dr. Hans HOFLAND from the Netherlands.
Hello, can you hear me?
Yes, go ahead.
Okay. I seem to have a problem with my video, but I'm trying to work on that at the same time. But I do apologize for that. Okay, hopefully it will work soon. So my name is Hans Holland. Thank you for the kind introduction, and thank you for inviting me to talk on the treatments and new treatments that are there for neuroendocrine tumors. Next slide, please. So when you have a neuroendocrine tumor, there are multiple treatments available to you, and it depends very much on your individual situation, the tumor that you have, which is the best option for you. So luckily, we have certain interventions that we can do that can either operate on the tumor or do, for instance, a liver embolization. And on top of that, we have certain medical therapies. So there have been a lot of developments in the surgical field, and also when it comes to endoscopic resection and, for instance, ablation of tumors in the recent years. But for this talk, I will focus mostly on medical therapies, those that are currently available, and the things that are hopefully coming as well. Next slide, please. So we have several groups of different types of drugs and treatments for our patients that work against the neuroendocrine tumor cell. And these have been developed in the last 40 years, and luckily we are seeing an uprise in the new treatments in the last few years. Here in the cartoon, you can see a neuroendocrine tumor cell, with on the outside the cell membrane that holds the cell together, which have certain what we call receptors on it that we use for treatment. Then inside is the machinery of the cell, where we have certain targets for treatment. And on the lower part of the cartoon, you can see the cell nucleus, which holds the DNA. And there also we have drug targets, particularly with chemotherapy. And I will go over some of these with you tonight. Next slide, please. So first we have some somatostatin analogs. It's already been mentioned tonight. This is an analog of a naturally occurring anti-hormone called somatostatin, and we know that injections are favorable for the complaints and tumor growth of patients with neuroendocrine tumors, and it's been around for approximately 40 years. So they decrease hormonal production, can improve symptoms, and reduce tumor growth or stabilize disease. There are two main types of somatostatin analogs on the market, octreotide and lanreotide, and in the coming years we're hoping to see new data of new formulations of octreotide. There is currently in clinical trials an oral form of octreotide that you can take in capsules, and we're waiting to see whether this helps patients with CarciNor syndrome. And there is also a new subcutaneous form that patients might be able to self-administer instead of the current injections that are often administered by nurses, and can hopefully help them as well control their symptoms and stabilize tumor growth. So hopefully in a few years' time, we have data and availability of this, but currently it is not available yet. Next slide. Then we have PRRT, or peptide receptor radionuclide therapy. This is a form of internal radiation therapy through the administration of radioactive somatostatin analogs. So similar to the previously mentioned somatostatin analogs, these work on the cell membrane, on certain type of hormone receptors that are on the cells. And we have now, for a couple of years already, lutetium dotatate approved for the grade 1 and grade 2 neuroendocrine tumors of the pancreas and the bowel. And this year we have also seen that this drug, so lutetium dotatate, can have positive effects in higher grade tumors of the bowel and the pancreas. So that's a high grade 2 or a grade 3 well-differentiated neuroendocrine tumor in first-line setting. So this is the NETTER-2 trial. So this is a drug which is available in many countries, unfortunately not all. But now we also see that there is a new clinical development of lutetium DOTA-TOC, which is similar to the other drug, but has a slightly different binding to the receptors. And it's now being developed in clinical trials. So hopefully this will also be developed into clinical practice, that we can also prescribe this, leading perhaps to better availability in many countries for PRRT. And interestingly, this is also being developed for LungNet, for which lutetium dotatate is not now registered. Because of its very specific action, so we're giving internal radiation therapy through administration by the drug by blood, There are now several combination therapies that are being developed to see whether we can enhance the effect of PART by having an additional effect of the radiation. And on top of this, several trials are looking at alpha emitters. So lutetium is a beta emitter, which irradiates the tumor and a quite large part of that, but alpha emitters really work inside of the cell to which it is attached, and perhaps might be a better option in the future. Still in clinical trials, but it's promising for the future, and hopefully we'll know the results of those trials soon, and hopefully if these are positive, they will become available. Next slide, please. So then we have targeted therapy. This works inside the cell, in the machinery of the cell. It inhibits different signals that lead to tumor growth. And the most well-known options are everolimus, which is a drug that is registered for pancreatic neuroendocrine tumors and non-functioning lung and bowel neuroendocrine tumors. And we have several tyrosine kinase inhibitors. Historically, we have sunitinib for pancreatic neuroendocrine tumors. These drugs work on the receptors that lead to these growth signals. In China, we have surufatinib, which is registered for gastroenteropancreatic neuroendocrine tumors. And very recently this year, it was presented that cabozantinib, another of a drug in this group, is efficacious for reducing growth in patients with a neuroendocrine tumor in the bowel or the pancreas. And based on these results, other trials are now also starting and are on their way to look at other tyrosine kinase inhibitors, so other drugs from this larger family of drugs to see whether they work in neuroendocrine tumors. And they can be efficacious, but as the cartoon on the right shows, they have some side effects as well, which sometimes limit their use in patients. Next slide, please. Then we have chemotherapy. Historically, this is used, I think, since the 60s for neuroendocrine tumors. Chemotherapy leads to inhibition of DNA synthesis of fast-growing cells. So this can be cancer cells, but also fast-growing normal cells, for instance, in the bone marrow. Historically, we have streptozotocin with 5-FU for pancreatic neuroendocrine tumors, but more recently, we're seeing the combination therapy of oral capsules with capecitabine and temozolomide for pancreatic NET and NETs of grade 3. For neuroendocrine carcinomas, we still have platinum etoposide as first line, and trials are coming to see which is the best second line for neuroendocrine carcinoma, and hopefully we will have more data on that soon. Next slide, please. So importantly, we also have hormonal therapy. So about 1/4 to 1/3 of patients with a neuroendocrine tumor have hormonal symptoms. Of course, here, somatostatin analogs are often the backbone of therapy, but it's important that specific functioning syndromes also require dedicated supportive care. For instance, to reduce stomach acid production in patients with gastronoma. In recent years, we have seen telotristat, which is a new drug for refractory diarrhea and carcinoid syndrome. This is a serotonin synthesis inhibitor, so it reduces the production of the hormone responsible for the diarrhea. And a very recent report shows that there might be a positive effect of a new insulin receptor antibody in patients with insulinoma, and this is, will undergo phase 3 trial in the next year. Next slide, please. Then we have immunotherapy. So immunotherapy, of course, there's been a lot of excitement about this in the neuroendocrine tumor field, but in oncology in general. Historically, we have interferon alpha, which has been used in that patient since the 80s, but its use has been limited by the side effects that this has, and also in many countries, the availability is limited. The new type of immunotherapy called immune checkpoint inhibitors is really revolutionized cancer care, especially in melanoma and lung cancer, but thus far in well-differentiated neuroendocrine tumors, we have not seen a benefit, but there might be some benefit in neuroendocrine carcinomas, but we still don't know its exact role. Newer forms of immunotherapy, for instance, CAR T cells and bispecific T cell engagers, have been developed already for other types of solid cancers, but are still in early stages of development for NET, and well, not available outside of clinical trials as of now. Next slide, please. Then finally, we have the tumor agnostic therapy, and the next speaker will also speak a little bit about that, because you can target specific DNA mutations by precision drugs that have an effect specifically because of these DNA mutations. However, due to the limited number of DNA mutations in our patients with a neuroendocrine tumor, this therapy is rarely available in NET. On the right side, you can see a very large study across many types of cancers, where the NET is all the way at the bottom, having the lowest number of actionable DNA mutations that you can target with these specific drugs. So unfortunately, this is well, still in development, but thus far it doesn't seem very promising for the majority of patients with a neuroendocrine tumor. Next slide, please. Thank you for your attention, and I'll be happy to answer any of your questions. And hopefully get my camera working.
Thank you. Thank you very much, Hans, for this excellent summary of what's coming in the field. And we have the pleasure also to have joined this panel. Also, Mark MacDonald from Ireland, as you know, past president of INCA, and also Wendy Martin and Meredith Cummins from Australia, right? So I don't know what time is it there now.
Yes, I'm from Australia, and it is nearly 4:30 in the morning.
Wow. That's really something we need to thank you, this particular effort, really. And we have also Wendy Martin from UK. We can't see you, Wendy, but I guess you're there, right?
I am, yes.
Okay. All right. So welcome to this panel. Any comment from the panel to the topic just presented and summarized by Hans HOFLAND? Mark, welcome. The floor is yours.
Thank you. Yes, I mean, a wonderful presentation by Hans, and really interesting topics. But I suppose for patients in general, Hans, you mentioned new therapies like alpha emitters for PRRT, new oral SSAs. So, you know, when would you think that they might actually come into reality and patients might actually receive them? You know, are we looking 2 years, 5 years, 10 years? I mean, I know it's a guess, but what would you think of that?
It differs, of course, depending on the individual drug that we're talking about. I think the road for PRRT has been long, and alpha emitters will have the same issue, I think. There's now one phase 2/3 trial which is starting, but I think it will take a couple of years before the outcomes of those trials are known, and to get the registration and reimbursement might also then take 1 or 2 years extra. So I will be happy to see whether this would take place in 5 years, but maybe a little bit longer for the alpha emitters outside of clinical trials. For the oral solid analogs, this is already available for patients with acromegaly, so a growth hormone producing tumor of the pituitary. So there's been some work already done there, and this might be quicker depending on how the trial goes and how quickly patients can be enrolled. So maybe likely this will be within 5 years if it has a positive effect, which we have to see, of course. Still.
Hans, your camera is off. Maybe it's because you don't have good Wi-Fi, or are you aware of that?
Yeah, so my camera didn't start to work for some reason.
Okay,
So
that's fine. That's fine. It was just an accident. Okay, it would be nicer to see you, but that's just fine. We hear you perfectly. So Meredith Cummins.
Yes, thanks so much, Hans. That was a wonderful overview of current treatments and new. I know in Australia we are doing some trials with alpha, with terbium, which is Grace Kong at Peter McCallum. So it's really interesting to see what's happening with that. And when you were talking about the new SSA, were you talking about the Sorrento trial? I just thought I'd clarify.
continues on. Yeah.
Yeah. And when do you think we might sort of start to see some results from that one? I think it's closed for intake.
Yeah, so it's closed. So yeah, that's the recruitment rate of that trial went very quickly. What I've heard, it's very good, and good to see that we can run a trial quite reasonably quickly. So hopefully, when it's now closed and they get their primary endpoint, hopefully within 1 or 2 years we'll see what it does. But I'm not quite sure. I'm not. We're running the trial here, but I'm not that sure when we expect the first database outcomes. Unfortunately.
Yeah. And just one more question. In Australia, we use Folfox quite a lot for a lot of the GEP-NETs. Is that a regime that you use also?
We don't use Folfox in general for nets of the bowel, but sometimes we do use them for the pancreas in second-line setting. But it's not often used here with us. No.
I think it depends, if I may say, Meredith, it depends also on the growth rate, growth slope, and the proliferation index of your tumor, right? We tend to use more chemotherapy in higher grades. You know, if you have an G3, then on an G2 high, then chemotherapy is something you may consider, and sometimes for the so we use more chemotherapy for pancreatic primaries, but it depends also on this fact, okay? Because if you have a G3 net, colorectal net, then you may very well use Folfox. I think Folfox is quite used in France or Spain, depending on these facts. And sometimes we get also some mixed tumors, usually a higher grade. But that's a very good regimen also to cover, you know, adenocarcinoma and neck. So it is a very useful regimen, although the quality of evidence is not great. But yeah, Mark, hands up.
Hi, yes. So in the presentation by Hans, I noted a lot of restrictions on the availability of drugs for different types of net. For example, it was PRRT, was for GEP-NET, and there's some trials ongoing for LungNet. In the past, before the lutetium-177 was approved, you know, lots of different patients got access to it. Is that now being restricted? And if you're a non-GEP-NET patient, you know, can you access this therapy now? Are there difficulties in doing that, and what's happening there? And just also a sideline to that, I know that everolimus, you said, was for non-functioning small intestine. So if you have a functioning, does that mean everolimus is not authorized or not in the guidelines for being given? And just how are they treated, and how are patients going to get different drugs? How is that decided?
So thank you, Mark, for this important question. So of course we all have our preferences as doctors, as we discuss them with our patients, but we are also faced with the fact that reimbursement is an important issue in different countries, and availability is an issue. So I can talk about the Dutch situation, where I can treat patients with PRRT when they have a positive somatostatin receptor, but I know this is not the case in every country. So for us, I can treat a lung net, for instance, but I know this is not available for other countries. And the same for everolimus. I think in general it is used also outside the non-functioning bowel net, so in the functional. But the RADIANT-2 studies, because this was negative studies, did not lead to registration, at least by EMA, for this particular indication. But you see for these indications that different countries have different reimbursement programs. So talking about this on a global scale, I think it depends very much on where you are situated.
Anna, what's the perspective in Greece, for example?
Well, you know, we are like in Greece. We have a possibility to provide patients with drugs, even if they're not already approved. But of course, it's a very long and tedious procedure. So,
yeah, I guess there's a very wide variability across countries, and even within the same country. I can tell you, for example, in Spain, I can use PRT with a lot of liberty, but it's not the same situation in many other centers in my country. So it's really and then you are very right with the everolimus label, but in reality, I think many people use it in functioning tumors because the fact is that we don't have so many options for treatment. And in the end, we use a lot of label. That's reality, at least until we get more options. I think we have a number of questions from the audience. I think we should address. Okay, so there's a couple of questions on for lung carcinoids or NG3, the access to PRT. There's a statement, can access the lutetium PRT in UK via referral to centers running clinical trial only needs to be changed. I don't know if it's a comment or a question. And then this person, Mo, says a comment from Martin Weigert. Sorry, it didn't show. I'm not sure what it means, but I guess it's about access to BRT for lung carcinoids and also for NG3. That's one of the questions.
So for LungNet, we have retrospective data from larger centers that has used PRT that you see long-term response after PRT. But there is, like I said, now the first large phase 2 trial that is coming. And NEN-G3, I think you should divide it into NEC or NET. And for the NET G3, the NETR2 study showed that PRT can be helpful, but again, also it's very important that these tumors have a somatostatin receptor, and some of the NET G3 do not. So if there is a good uptake on the gallium dotatate or gallium dotatok PET, then PRT is an option here. Officially, it's not registered by the EMA label, but I think also here the off-label indication is used often.
Okay, there's some question saying which immunotherapy is preferable?
Well, I don't think there is a preferable immunotherapy at this point because we don't think it's helpful in NET. But also for NEC, we do not know whether particular immunocheckpoint inhibitors are better than others. I think that's still an open question.
Yeah, it's still not a standard of care, right? It's not approved, I guess, for any instance. So another question, how effective is everolimus in treating liver metastases?
So everolimus is effective for every type of metastasis, whether it's in the liver or in the peritoneum or in the lungs or in both. That does not matter particularly. So we know it has positive effects across several trials that have been run, in, like I said, pancreatic neuroendocrine tumors and non-functional bronchial and small intestinal neuroendocrine tumors. So it can be effective there, no matter whether there are liver metastases or not.
They were asking also what was the name of the trial of somatostatin analogs, oral somatostatin analogs? There was a question before about that.
I think the drug is called Mycapssa, but I don't know the trial name by heart, sorry.
Mm-hmm. Okay, what is the effectiveness of PRT at metastatic small intestinal NET?
So that's the NETR1 study. So we know when we give PRT after patients with a metastatic mid-gut NET have progressed on octreotide or lanreotide, and that PRT gives an overall disease control of about 30 months median. So that's the median time in which the disease is controlled. And there are patients that have a small effect, which might last a year, but there are also patients that can have positive effects for PRT for many years. And then depending on the center again, and the availability, you might also consider retreatment when PRT has not become effective anymore, but has led to disease control in the first instance. But this depends on the local availability.
Okay, I have a question for, I guess, patients, maybe also nurses, Wendy, regarding oral therapy versus subcutaneous or intramuscular. So what's your feeling regarding patient preferences, how they live? Do they prefer to take an oral pill every day, or they would rather take a shot once a month and then forget they are sick or something? What's your feeling about that? Is it always better an oral drug? And what about compliance issues too? I would like you to comment on both things.
So I have a lot of patients who will ask me almost every visit that they come, is there not a tablet I can take for this yet? So I think a lot of patients would prefer not to have the injection, but I think you bring up a useful or an interesting point there. Is tablets mean you have to think about having your neuroendocrine tumor every day versus having an injection once a month. I think our patients, from a compliance perspective, are a really motivated bunch of patients, especially if people have got functional tumors, because they know that the analogues will actually help with the symptoms and not just tumor growth. So I think it would be nice to have the option. I think for some patients, they might prefer to have an injection once a month. I think others might prefer to have tablets. So it would be nice to have the option.
And what about self-administration? I think this is maybe different in different countries. So what's the proportion of patients in the UK maybe that do self-administration, and how easy is that to teach?
So I think it varies from centre to centre. So for us as a centre, we're very keen on the benefits of self-administration, where patients can then take more control of their disease. It's easier for them to travel because they can take their injections with them. So we have it as an option for all patients. Some patients, it's a bit too overwhelming to start out with self-injections. Sometimes it's something that they come to a little bit later when everything's kind of settled down. They've got used to having a net, they've got used to having injections, they've got used to managing side effects. So I think we have quite a high proportion of patients who self-inject, but I think it very much depends from centre to centre, and patients again are very concordant with self-injecting. As I said, they're a highly motivated group for managing cancers. They want to manage their disease, but again, self-injection isn't for everybody. I know Mark and I have talked about this in the past as well, but I think again it's nice to be able to have the option, and in the UK we're able to do that.
Okay, we have 1 minute to go and 3 hands up. Stephanie, sorry, you were with your hands up. I was trying to address the public. Shall I skip you, or do you want to?
Go ahead and skip me. I had a long question with
So I'm
probably
not
some
sure
answers. Go ahead.
Okay, between Mark and Meredith, who was first? I didn't notice, sorry. Okay, any of you jump in.
Mark was first.
Okay, Marcus.
Go ahead, Meredith, go ahead.
I was just adding to what Wendy says, being, well, an oncology nurse as well as being the CEO for Neuroendocrine Cancer Australia. We have sort of done some studies as far as pills versus subcutaneous and everything. People would love to have a pill, but as Wendy said, it is a reminder every day that they have got neuroendocrine cancer. But also there's a question of absorption as well. When they've got a lot of diarrhea, are they actually going to be absorbing as much of the drug as they would be having the subcutaneous? And I think with the Sorrento trial, depending on the results and everything like that, I think the fact that it's every 2 weeks that you have the injection and it's more like an insulin needle, so it's much smaller, it's much easier, and plus the fact that it doesn't have to be refrigerated, it gives patients a lot more independence. But again, we just need to wait to see what the results are going to be like. And self-administration in Australia, it's possibly about a third. We've got more patients who are wanting to, but it's depending on what product they're actually having. But a lot of the time it's the partners that are learning how to do it so that people can have a lot more freedom to go and do things, not having to go to the hospital or not having to have a GP trained up to do it. So, yeah, that was my input.
Thank you. Thank you very much. Thank you. Thank you, Hans, Wendy, Mark, Meredith, and Anna for your excellent contribution. And I think we are going to move forward to the last topic. Stephanie, welcome, Ilaria.
Yes, thank you so much. And now for our last discussion about genomics. We'd like to introduce Ilaria to present the clinician's perspective on this. And this should be of great interest to many patients, especially as well as those who unfortunately will be diagnosed in the future, because this is understanding the molecular biology of the tumor and using it to better treat the illness. So I turn it over to you, Ilaria.
Thank you very much. Thank you very much for inviting me. It's a great honor for me to be here today. Yes, as you mentioned here, we are just moving a bit to the future. Not always. I mean, some things are already in place, but of course, the idea that behind us looking at the genomic or the molecular features general of these tumors is try to have as many information as possible, which can help us to understand why the tumors is growing, why is progressing, what are the characteristics of these cells in order to better tackle and to target them. So next slide, please. And one of the easiest thing that we can do is, as was mentioned before, is looking at the mutation of the DNA which these tumor cells carry, because you may know that the cancer cells, in order to be able to progress, so in an uncontrolled way, they have to accumulate a series of mutations in the DNA which allow them to grow, to progress, to invade new tissue, to invade the vessels. And the interesting thing is that we can sequence the DNA, so we can look at all these mistakes or mutation that these cells have. And in some cases, once we see them, we find them, we can also target them. So we can revert the phenotype that these mutations are inducing. For example, if it's uncontrolled proliferation, we can somehow stop this and revert or even kill the cells. The drawback, as was mentioned before, is that it's true for neuroendocrine tumors, this is still probably not the new kids on the block, because they have a very low mutational burden, but it's not the case for high-grade neuroendocrine neoplasm. So when we talk about G3 or NEC even, they have a high mutational burden, and there might be a lot of mutation which can actually be targeted. And what is interesting is that what we do in the majority of the case, mutation, looking really extracting the DNA from the tumor, so from biopsies, from surgical specimen. Nowadays, we can also look at the mutation of the tumor cells just in a blood sample, so from blood withdrawal, because the tumor cells somehow release the DNA, which is called cell-free DNA, which is found in plasma. And sequencing that, we can also look at the mutation of the tumor and, yes, come up with ideas on new treatment, or also understand how the biology of the tumor, so how the tumor progresses and what the mechanism lies behind the progression of the tumor. Next slide, please. So we can look at so this is one thing, so the mutation of the gene, but of course, as you can imagine, the molecular profile are much more complex than this. And we cannot just look at the mutation, but we can also look at certain modification of the DNA. So the molecule of DNAs is subject to many modifications which change the structure of the DNA, which then can switch on or switch off specific genes. So again, the result is the same. Some genes are activated, which may induce proliferation of certain phenotype to the cancer cells, and some other may switch off. And this is one of these modifications is DNA methylation. And we can easily look at this also, profiling the DNA methylation of specific tumor, then analyze this. And what we know that in neuroendocrine tumor, this is very precise in identifying subtypes of different NET. For example, in the pancreas, we know that with certain different epigenetic profile can tell us whether the tumor will have more chances to metastasize or to progress and to relapse, or whether the tumor, it's more like, seems to be like quiet and not growing that much, and the risk of relapse is much lower. And we can also look at specific modification in specific genes, like for example, the MGMT promoter. And this may be also predictive for a specific response, for example, temozolomide. And this is just a study which we have conducted within ENETS, supported by ENETS. This is not yet there. This is used for other tumor, but it seems that also NETs may have a sort of value in predicting response to temozolomide. Next slide, please. And then we can also look at the biomarker. What is a biomarker is something which is present in the tumor cells compared to a healthy tissue. So it's something that we may not have in the healthy tissue, which can tell us which can use for recognize the tumor, but again, to also understand the biology of this tumor. So if these markers are there, it means that certain mechanisms are activated, certain pathways are activated. Certain pathways are again leading progression of the tumor, invasion, or any different pathways or characteristics that the tumor cells needs to have. And again, once we know which are the pathways and the mechanism activated in the cells, we can think about targeting them, because we can understand how the tumor behave, but we can again try to target. Definitely, the more we know, the more we are able to treat the disease in a more precise way. Next slide, please. And we can look at the RNA sequencing, for example. This is done on a research base. It's not used in the clinic, but it's used to, try to understand what's going on in the tumor. And this gives us an overall idea of what is going on. It's not just one marker. It gives us the idea of many pathways which are dysregulated in the tumor compared to a healthy tissue, or compared to different subtype of tumors. So some NET may have a certain mechanism and some may have other and might be treated in a different way. But we can also look much easier at expression of specific protein, which we call biomarker, and very easily on the tissue, on immunohistochemistry, as was mentioned before. Just Ki67 is the same it's just assessed by immunohistochemistry. We can look at, for example, one of these, but there are many others, as the DAX80X, this loss of expression of this protein, which often correlates with mutation. It tells us that the tumor is a tumor that may grow, may have a very high risk of relapse. Therefore, we have to consider that this patient that may have this expression of lack of expression, in this case of this biomarker, may have a different treatment compared to tumor that don't have. So these are, again, this is just one example. We have many others that we can look at. It's just to give the idea that the more we know, the better we can treat the disease, of course. Next slide. And again, this is really for the future. It's not there yet, but to understand better the disease, it's clear that we need to have preclinical models which are reflecting the biology of the disease. And here, in neuroendocrine tumors, unfortunately, neuroendocrine tumors are always behind in terms of research because it's difficult to model them, it's difficult to study. But in the last days, there's been a big step forward, in this respect, we have now some organoids line also isolated from neuroendocrine carcinoma. We also have some other way of cultivating these tumor cells, which we call tumoroids, which are definitely closer to the real tissue situation. And using these models, we can definitely hope to move forward and to propose new treatment and new care for this disease. So again, I had just 10 minutes, so I cannot show you everything is going on. These are just few techniques, few tools that we can use. The field is exploding. There are many more complicated molecular assays we can do. It's really now moving very fast, and we gather a lot of information with the new technologies on the tumor. So I think the future is bright because we get to know many things that we yet don't know. So thank you very much.
Thank you, Ilaria. Thank you very much. We have for this last panel still with us Mark McDonald, I think Meredith Cummins, Wendy, of course Stephanie and myself, Hans HOFLAND, and the speaker Ilaria. So we have a question from the audience. Maybe we can start with this. Oh, sorry, Stephanie has her hands up. Stephanie?
Yeah, I was just curious, Ilaria, you mentioned that oftentimes neuroendocrine tumor research is a little bit behind in some of the emerging areas. And I was curious if you had any examples of other disease states or cancer states where this has progressed even more, and some examples to give our patients some hope about what the future might look like, and and to look to other disease states at that.
So that's not an easy question because, of course, the biology of the disease is very different, right? So again, there are many melanoma, for example, with a high mutational burden. Paradoxically, it's easier to treat than a slow progressive tumor with no mutation. The immunotherapy works because we know that, and you also have in lung cancer also target therapy based on a molecular profiling. And if we're looking at really basic, for many more aggressive cancer, like pancreatic ductal adenocarcinoma, or we have a lot of in vitro models which can be used also, these organoids line, which are used to predict the response of the patient in the clinic, just doing drug screening. So of course, you always have to deal with the biology of the disease. So you cannot make a model that proliferate more because you want, so you have to stick to the biology. So this is a big limitation, but I mean the field is moving forward, and the technology is getting better. And so if I compare with when I started to work with neuroendocrine tumors 10 years ago, the field changed completely, and there is more scientists also working on neuroendocrine tumors for sure.
And I just wanted to add a small comment from, because I'm older than Ilaria. She mentioned a couple of diseases that, saying, melanoma and lung cancer, they have so many options and so on. I've lived at times where melanoma and lung cancer were really dreadful and had a really horrible prognosis and had no options but very ineffective old chemotherapy, and that was it. And I have lived that with GIST, also the transformation. I was actually in Boston when the first patient was treated with imatinib. So I think we really need to emphasize how important research is, because it really moves the field forward. And I think we need to really reinforce this idea to all patients and to all physicians and to all hospital managers and so on, because I have seen already in my professional life major changes in many tumors. So we are going to see that in neuroendocrine tumors too. So, Mark?
Thank you. So I'm just wondering and curious, are we, by that description of this subject area, are we moving towards individualized treatment where a person is going to be tested for genetics and biomarkers, and that then dictates the type of treatment they're going to get? But if that is the case, then we're very dependent on the type of centers to have the technology to do that, the cost of doing that. So yeah, so that's really my question. Where do you see this all going, and can we really accommodate this?
So of course, I mean, this is, as you say, it's different, as you mentioned, it's different country by country, and it's for sure you can access certain certain of these tests in certain center and not in others. That's clear. A bigger center may have more of these facilities than the small one. I think what is important is that I think the work of the researcher or science is try to identify what molecular assays, what tests are meaningful for each type of cancer. We don't have to do everything on everything, because as we say, net probably sequencing is not going to help us much in terms of identify a target. So we just have to understand and be smart and do the test which we need to do to select the therapy or to understand the development of the disease. That's my idea, I would say.
There's a question from the audience here, Ilaria. Are there already some mutations known that were observed in NET or NEC?
Yes, so in NET, fortunately, yes, they are known, but we cannot target them yet. For example, as I said, DAX and ITER-X is mutated in almost 40% of pancreatic non-functioning neuroendocrine tumors, but yet we don't know how to target. MEN1 is known to be mutated for, I don't know, 25 years, 20 years, but we still don't know how to target. But it's different in the next setting, where we have sometimes BRAF mutation, which can be a target, or it's not really a target therapy. So we know that if you have a high mutational tumor burden, this may qualify for certain immunotherapy. So in NEC, we do have some of these target that we know of this mutation, and we know that we can target.
Yeah, I guess it's always more easier to target oncogenes. So
yes,
genes that are activated, kinases that are activated, and so on, that is easier to inhibit. Something that is hyperactivated, that to restore a function that is lost, like tumor suppressor genes.
Exactly.
When they are lost, they increase the risk of tumors. But of course, to restore a gene that has been lost is much more difficult. But in NEXT, for example, I think there are other alterations that may be targetable in a very near future, because NEXT of the GI tract have profiles that are quite similar to the non-neuroendocrine counterparts. So beyond BRAF mutations, as you mentioned, we have KRAS mutations in pancreatic NEXT or in colorectal. And this is not yet standard of care, but KRAS inhibitors are getting better, and they are inhibiting a broader spectrum of mutations. And I think there are things coming that, may really end up having an impact on patients. I think Meredith has her hands up.
I do, yes. Thanks, Ilaria. That was fabulous. And in Australia, there is a lot of work that's being done, and there's a lot of activity with a group who are doing all advanced cancers, including NETs, which is very interesting with doing the genomic sequencing. But I'm just thinking, sort of like, you're doing so much wonderful work and there's all this happening as well. Is there collaboration internationally as far as what you're testing and what you're seeing? And yeah, so that we're not reinventing the wheel everywhere.
So this is the case, I hope, it should be the case it always, you know, in the scientific community, there should be network and sharing data. I mean, it's not always happening that nice as one would like to, because you know, you want to publish, you know, you have other sometimes it's tricky. But in the net field, I have to say that this the network is extremely because it's a small community, so people, really scientists and clinicians, also collaborate very well together. There are a lot of international networking, just also because it's a rare disease, so you need to sometimes to share samples, expertise, to have meaningful studies, you need a larger collective. So I have the feeling that in the net field, this is particularly true. It's happening a lot, and the scientific community is really collaborating a lot. And ENETS is also supporting a lot of collaborative studies and enforcing a lot the collaboration across different countries.
Hans?
Yes, thank you. So I just want to support Ilaria here in her talk on the scientific developments, and also in our lab and our experience. Is very important that we, together with the patients, do this research. So if you are in a center where there is the possibility for research and a translational research, so we use blood or we use tissue, and you want to participate in that, we highly applaud that, and we really need the patients to be able to do research, and we need, because of the rarity of this disease, we need a lot of samples to really see what's going on and what is causing this cancer. So as a patient, I think you can really help us, help you in the end, and help others as well. So just a small plea that if your doctor asks you if you want to participate in certain biobanking or database research, I think you can help us massively with this.
Yeah, I'd just like to clarify, if that's okay, because I think that's a really important point, is that patients can participate in research, not through necessarily an interventional trial where they're put on this drug or this drug. This is an opportunity for patients to passively participate and donate their tumor tissue at the center or another center. And so this is something that wouldn't necessarily affect your treatment. It's something that would is done behind the scenes, and ways that you can participate in research that's really important. So I think this is an important learning lesson for patients, is that they can participate in ways that really are, you know, no skin off their back, so to say.
Yeah, I think this is very important. I mean, the comments by Hans and Stephanie, I completely endorse them. I think it's really important. It's a responsibility of all of us, of treating physicians, to really pursue this and explain and dedicate time to explain patient how important this is, and patients to contribute. I think personally, I've never had any patient that said no to donating an archival tissue or, you know, a blood sample. Honestly, you just need to dedicate efforts to, you know, have your protocol, have your consent form, explain the patient why it's important, and so on. And even without samples, gathering clinical information, because this is not such a common disease. When we pull all data together, we can learn as clinicians a lot of things to help us when fill the gaps that are not filled by clinical trials, you know, because we don't have clinical trials to answer all our questions. And I think the ENETS database is also a unique tool and resource for all of us, and also basic researchers that want to work with samples linked to good quality clinical data. I think it's a unique opportunity to really gather big numbers that can help us address better all these questions. And I really encourage all of you to participate in this. Mark?
So on that topic, I mean, I think that there are probably a lot of patients that would like to contribute and to be helpful, but probably or possibly their own centers or their own countries don't have that linkages into you. So I don't know how, but if it could be somehow, made possible for patients to participate across different countries or across regions, I'm sure there are many patients that would like to, but they just don't have the pathway to help. So if that could be done somehow.
Yeah, I mean, I think that's a very good point, and it's of course all has to do also with resources and capability, but it is also our responsibility in the society to try to build up the network bigger and bigger, so that it can get to all centers, because such a thing, I mean, not all centers are prepared to do high-tech, leading research, but all centers can contribute with patient samples and patient data, clinical data. All patients can really do that. All patients, I mean, all centers and all physicians, even if they are not super into, I mean, this kind of contribution is really feasible from a very low complexity kind of centers. So I think there's a lot of work to do at different levels, and also at our level, there's a lot we should.
If I may just say something, because of course, I mean, there is many different samples that one could gather, and of course, if you need the fresh samples, of course, you have to be in a kept institution with a researcher and facilities. But we can do a lot also from a paraffin block, and this is everywhere. Every pathology institute in the world has a paraffin block of the tumor. So this, I think the patient may have really the power of saying, yeah, I want that this goes, I don't know where, that if we can use for research, they should. Again, it's not always fancy things. It's very old school. We do also things with old-fashioned material.
Wendy?
So that was a point that I was going to raise as well. It's about raising awareness of different types of research, because I think a lot of patients, when they think about research, are thinking about trials and experiments, but it's about how we can use data, and even just collecting symptom data and how people respond, or there's all sorts of things, as you were saying, that we can use for extending knowledge. So it's about empowering patients to feel that they can actually ask, is there any research that I can be involved in, or can my data be used to help with research? So I'd encourage any patients to talk to their teams and see if there's any way that their data or information can be used without, as we say, it doesn't always have to be actual treatment trials, for instance, that people might not be appropriate for.
And I guess the last question from the audience, let me see if I get it right. Kevin Walsh is asking if on a tablet every day as opposed to injection every 28 days, do you suffer the same side effects from the tablet on a daily basis?
Okay, this is not for me. I think
I guess
you
for
have to
Hans.
answer this
Hans
question.
can address this question. Right.
So we still have to find out. This is still a clinical trial that's ongoing. I think the safety signals or the side effect signals from the trial in other types of patients seem that it's well tolerated, but NETs have their own pathology, that it's a different disease. There are a lot of bowel complaints in NET patients compared to patients with acromegaly. So we need to see how the trial works out and what the outcomes will be. So the short answer is we don't know yet.
We are studying it at least. We will know soon.
The answer is always more research. We need more.
Yes. Okay, so I guess we are coming to an end. Thank you, these latest panelists from the fourth topic of the day, the speaker, Ilaria. Thank you very much, Hans and Meredith and Mark and Wendy. And thank you, of course, Stephanie, for putting all this together. I think it's been really very interesting, for very important topics, and with a very good participation participation, both of the public and also of the of all panelists that were invited. Of course, we could be here for many hours discussing. Thank you, Gregory. I see you are still there, and thank you, Wanda, and all the other contributors, Lisa, Marge, Nehara, Theodora, you're back there too. I see you, and all the participants. We had a lot of participants tonight. I don't know if we have some closing slides, Leah, that you can share. Okay, so this is now coming to the end. This is our annual ENETS INCA Net Cancer Day educational webinar. Is coming to be a recurrent activity that we do with great pleasure to really provide visibility to this important tumor that affects very many patients. We all know. And, you know, also to learn all from each other. We learn from patients, and I think patients that joined today also were able to learn from our invited speakers. So big thank you to all of you, to the speakers, to the moderators, discussants, to the INCA office, and Theodora Kolarova and Isabella Oronova. Thank you so much for all the tremendous work you do at many levels. Thank you, of course, to the ENETS office, Martina Fleschen, Rinel, and Leah Matthews, for your great job too, and the ENETS education group that designed with INCA this webinar, and of course all of you, all the participants that have been staying until so late at night. We very much appreciate and value your interest and contribution. So if you want further information, you have here the links, the QR codes for the INCA Alliance and also for the ENETS webpage. So and thank you also to all the sponsors that contribute to our webinars and that are also very important. AAA, Novartis, Cameros, Ipsen, and SERB. So we really thank our sponsors for making this generous contribution too. Thank you. And here you can see the map of the ENETS Centers of Excellence. I hope it keeps growing and improving patients' care and patients' care of a greater number of patients. We have now 68 centers worldwide, but we hope to have many more. You can scan here also the QR code to access the ENETS Center of Excellence that is near you. And next, okay, you can follow us also on social media. We are now in LinkedIn, we are in X, and we are in Facebook. So through there, you may find all the activities that we do and that we hope that you find of use. So you may also join INCA on social media. Sorry, they are in Instagram too, and so thank you very much. Thank you, and have a nice evening, and hope to meet you soon again. Thank you.
Thank you. Bye-bye.